Hey, thank you very much. How do I make things happen? Okay, thank you. There's a blank screen and I have no remote. It's a psychic presentation. So, as Rob mentioned, we began our work without knowing there was going to be a draft guidance, and so we're going to be presenting data that were designed to inform more broadly considerations of rights and welfare of participants and other interests of stakeholders for this kind of research. When we say this kind of research, we're talking about the types of research that are being conducted in the NIH Collaboratory and PCORNet, whatever you want to call that. And so this work is supported through the Collaboratory. Rob is our PI, and Jeremy Sugarman and I are the project leads on this, and we lead teams at Duke and at Hopkins.
This is not a disclaimer, Kevin, but I do feel obligated to say I'm the PI because that's the way the grant is structured. It's not because I'm the thought leader. It's really Jeremy and Kevin have a history of empirical ethics research and should be acknowledged as the real leaders of this study.
Okay, well, thank you. So I just want to let you know that what I'm presenting today is part of a program of research that includes formative stakeholder interviews, clinician interviews that are ongoing, patient focus groups, which is what I'll concentrate on today. This will be followed by a national quantitative survey of the public, and then interviews with key individuals who are involved in human subjects oversight to share our findings with them and get their reactions. So we're just going to talk about the patient focus groups. We're most of the way through with those. We've got some interim analyses, and I'm going to tell you 4 things that we've learned today about those. But let me tell you about the groups themselves. The groups are conducted in 5 different cities around the U.S. to try to get a broad representation. And we were targeting adults who had seen a provider or been to the hospital sometime in the last year. So these are all people who have touched the healthcare system in some way. And people participated in one of 2 kinds of groups. One type of group led people through a discussion of a research study that involved individual randomization to pharmacotherapies. It was basically pain medications for back pain, right? And we would start out talking about a clinical visit for back pain, and then talking about a situation where you might be randomized to one of 2 FDA-approved medications for back pain. So we've got 6 groups under that scenario. And then we've got another 6 groups where we're working through 3 different scenarios involving cluster randomization to interventions that have to do with medical center operations. So hand washing policy, different educational programs for surgeons, different pop-ups for potential adverse drug interactions, those sorts of things. So today I'm going to report on 4 of the 6 groups of the first kind that were analyzed, and 2 of the 6 we've analyzed in the other category, and that's a total of 81 people. And I'm not going to go into the participant characteristics. We can in the discussion if you like, but I want to get right to the fun here. Our objectives for the focus groups were 3. The first was to try to get participants to understand the standard of care research scenarios that we were describing. And that was more difficult than we thought it was going to be. The second thing we wanted to do was to discover the considerations, which we call the needs and interests of participants, that they use when they're thinking about different consent models. And we came up with a technique to elicit these considerations that I'll show you in a minute. And then if we could do the first 2, to try to understand the acceptability of different consent models for different kinds of standard of care research designs. Okay? So in our discussions with people, we started out with 4 different models of notification and authorization that I think everyone here is familiar with. General notification, oral plus an information sheet they could take home, and express written consent. And for the groups in which we were looking at individual randomization to pharmacotherapies, we put these different models up, we defined them, discussed them, and we asked people to consider the pros and cons of each of them. And so we actually had sheets up on the wall, and we would jot down people's ruminations about the pros and cons, and they could look across all of them and discuss these. It generated very rich conversations that were helpful for us to try to figure out how people are construing these different options and what kind of goals and interests people had that they thought might be met by their understanding of these different models. So let me get to the 4 conclusions we've got based on our interim analyses. And just again to stress, we are still analyzing data. We still have 2 more focus groups to conduct. So we don't like doing this. We wish this meeting were at a different time. So we're incredibly uncomfortable doing this. But we will go ahead, the spirit of uncertainty. So conclusion 1, it's difficult for people to understand CER with individual randomization. It was very, very hard for people. And this is actually, we learned some things that were contrary to some of the comments that have come up today. We typically hear people concerned about a therapeutic misconception, that people are going to come into research, and what we need to do is spend a lot of time disabusing them of all the different things that are not being done for their personal care. For the type of research we were looking at, the challenge here was that as soon as you said randomization, everyone imports all of these associations they have with trials of new therapeutics, even though you said these are 2 safe and approved pain medications, they've been used for years, right? Even though it's written down. And so over an hour and a half of discussion, we found that even after we improved our educational materials with the help of Ben and David, we made our own little videos to help people understand. They worked. It took a lot of time. But it's still, these associations would creep back in and you'd have to give another clarifying comment for people. So actually the force of that association with experimental therapeutics was very, very strong. We didn't anticipate that, and it was one of the more interesting findings. Our second conclusion is that people's needs and interests differ depending upon the type of standard of care intervention being tested. And so to the point that people have raised earlier today, a guidance document that's intended to address standard of care, usual care interventions, needs to take into account that people see these differently. So for example, in our groups on your left there of individual randomization of pharmacotherapy, we've analyzed data from 4 groups. There they are. In all of those groups, people's need to be informed about the study manifested as a need for active informing. They wanted someone to come and tell them about it, right? General notification of something up on the wall or on a website was generally not felt to satisfy their need to be informed there. For the 2 groups that we've analyzed, though, where we're discussing different varieties of cluster randomization and medical center operations interventions, in both of those groups, there were people who were saying that, yeah, I think that people ought to be notified, but just general notification's fine. Website, flyer is fine. And other people were saying, I actually don't think there's any need to notify anyone about these types of studies. Right? So the important point here being that when we're trying to make statements about this general kind of research, we just have to recognize that there are actually lots of different types of interventions here, and those differences matter to people. Conclusion 3 here is that people don't want disclosure to artificially increase their perception of the risk. We were impressed with the sophistication of a lot of our participants, and we were also impressed at our ability to get a really nice wide variety of participants in terms of educational background and such. And so it wasn't the case that we had a bunch of PhDs from the Research Triangle area. This is a pretty broad group. And people were fairly astute in understanding how different consent models might encourage different understandings of risk that may not be true. Okay? And so let me give you a couple quotes. Like, the more and more involved the consent process is, the more the people perceive that there is the potential for something bad to happen. So they're looking across those consent models from general notification all the way to written consent. They're saying, you know, as you go there, people are going to assume that what's being done is riskier and riskier. This is a great quote. It illustrates not only this point, but also some struggles with this kind of research. and it's tough to get, but just hang with me. It's going to start bringing up things of, you know, what am I signing for? He's talking about written informed consent. Why am I doing this? Why? You know, this is new. Must be a new medication that's coming up that they want to test. Keep in mind, this is after we've gone through tons of stuff about how these are too safe and approved. Not that it's been around and is safe and effective. I'm going to start thinking, questioning the safety and effectiveness of these medications, and that's not what I'm doing. So he's understanding that's not what this study is about. I'm actually just signing, do I want the computer? Do I want the doctor to make that choice about which of the drugs to get? But all that's blurred now because we've just had this discussion with them giving me this long thing, consent document. I've been in medical studies before when I've got the thing and I've consented to all that and everything. That's for that kind of study. That's what's going to be in my mind. I'm testing. I'm the guinea pig for this. I'm whatever. Versus somebody saying, oh, let me just tell you about this. Instead of me choosing, it's a computer, yes or no, that's all I need. Okay. Conclusion 4. We were analyzing people's needs and interests that seemed to inform their perceptions of what was going on here. We found a lot. People have many different interests and needs related to research on standard of care. We found 10 of them, which I'm happy to go through if we have time. There are a lot of different needs here. It's not just the need to know what the risks are. So there are a lot of interests that need to be respected here. And that people understand that some needs and interests may be in conflict, requiring trade-offs to be made. Let me give you another example here. Notifying the public, would be nice, but it would change the study. It's exactly the same. They're talking about an operations intervention here. It's exactly the same as if you're testing how efficient teachers are at teaching, and you tell the students your grades on this test are going to be used to measure how well your teacher does, and the student is like, I hate this teacher. I'm going to fail every question so that my teacher gets dinged. It's a different study. They shouldn't be notified. So we heard several people very aware that some kinds of notification in certain situations might cause people to behave differently, which might threaten the validity of the research that they felt needed to be done. And so they concluded that the need for valid findings in this area outweighed the interest in being informed here. So here's 3 of the needs and interests of the 10 we found. One's to be informed of the study. But other ones we heard were greater certainty about treatment effectiveness. People desperately want there to be certainty about the most effective treatments. That's a strong interest. Study designs that generate valid information, another strong interest. And people were talking about ways in which some of these interests had to be traded off with respect to others. And so I'll just put these 4 conclusions up here again. It's difficult for people to understand CER with randomization. It took a lot of effort to do it well, and even then we're not entirely certain that everyone could understand it. People's interests differ depending upon the type of standard of care intervention tested. They don't want disclosure to artificially increase their perception of the risk, and people have a lot of needs and interests that sometimes conflict and require trade-offs. And I'm going to end there. So we've got.
I think that's great, Steve. I think you're in charge of the overall meeting at this point. Is that right? So, just thinking about logistics, what I think would be good would be for David and Ben to go and then have a discussion about the questions about the research itself. Then tomorrow morning we have about the same time allocated. We have 2 others, but really one of the others doesn't have results yet, so that's going to be very brief. And what I'd suggest is we'll have a lot of time tomorrow morning, relatively speaking, to talk about what this all means. So we sort of focus on the research itself today. Then you can sleep on what it means and talk about it tomorrow.